All right. Well, hello, everybody. Welcome, and thank you so much for joining us this evening. I'm Marcy Rubik. I'm the Executive Director of the Limb Preservation Foundation. And whether you are a medical provider or a patient, we know that you are going to get a lot of great information this evening that you will be able to apply immediately. So we just want to express our thanks and let you know that the slides will be sent out to everyone following the program. It might be at the beginning of next week, but please do watch for those. We would like to thank our sponsors, Allosource, Health One, Diversified Radiology, and Ben Binder. We would also like to thank all of our speakers this evening, as well as their partnering organizations with Press St. Luke's, UC Health, and Denver Health. And we appreciate all the speakers that you're going to meet shortly. And then last but not least, we are very excited to have our moderator this evening. Jenna McMullen is a board member for the Limb Preservation Foundation. She is a two-time cancer survivor, overcoming Ewing's sarcoma when she was 18 years old, and is grateful to be living with an artificial knee and femur. She overcame breast cancer in 2017. She is a leader in the field of communication, in specifically space, and she joined Lockheed Martin Space last year. She is dedicated to serving our community, and we are very grateful to have her with us this evening. So please join me in welcoming Jenna.
Thank you, Marcy. Really appreciate that warm welcome. And I'd also like to extend a warm welcome to everyone who's joining us here tonight. We've assembled just an expert panel to go through the limb journey together. But before we take a look at the agenda, I do want to share a handful of housekeeping tips. You may note that each of your microphones have been automatically muted. We'll be utilizing the chat function for any questions or comments that come up during the presentation. But be thinking of those questions, because at the conclusion of the panelist presentations, we're looking forward to a robust question and answer session. So we certainly want to hear what's on your mind and make the most of the time we have together with our experts. We also have closed captioning enabled this evening, so you can locate that with a live transcript at the bottom of the toolbar there. That's also where you can find your chat function, so don't forget about that. And then finally, as Marcy mentioned, we will be sending out the recording of this session as well as the slides likely next week to all of those who registered. We'll additionally post them on the Limb Preservation Foundation website. And finally, stick around, because also at the conclusion, we'll be doing a drawing for a $100 gift card for those of you who attended this evening. So little incentives there. So with that, let's take a look at our agenda for the evening and what we have ahead of us. As I mentioned, we have three fantastic experts here with us to take us through the limb journey together. And I'd first like to introduce Dr. David Schner, who's going to be our first panelist here. We can move to the next slide here. So warm welcome to Dr. Schner, absolute expert with extensive expertise in limb conditions, corrections. We'll be hearing a little bit about both tonight. So with that, I'll like to hand it over to Dr. Schner. Welcome, and thank you for being here.
All right, thank you so much, Jenna. And I want to extend a welcome as well to everybody. We certainly appreciate you joining us tonight. I'm going to give you a little bit of more of an introduction of myself. I'm a plastic surgeon. I've been here in Denver since 2003. Started at the university and then joined the plastic surgery clinic here at Presbyterian St. Luke's. I'm the medical director for the Institute for Limb Preservation, very involved in the Center for Advanced Amputee Care here as well, which is very intimately connected with the Institute for Limb Preservation. And so I do a lot of upper and lower extremity reconstruction. I do a lot of upper extremity trauma as well. I'm involved in a lot of amputation in the lower extremity, mostly as a secondary procedure, but you know, very knowledgeable about sort of the primary procedures as well. So next slide. So I'm going to talk a little bit about the kind of surgical considerations in amputation care. or an amputation surgery. And I'm going to talk kind of in two parts. First, I'm going to talk about the care in the kind of the immediate, amputation, either immediate trauma or kind of during the start of the amputation journey. And then after our other two speakers, I'm going to come back and I'm going to talk about secondary procedures, which is another area that I have a fair bit of expertise in. And then again, I'm happy to answer any questions. Please think of your questions and I look forward to them. So sort of, amputation surgery is divided into two sets. And the first set is sort of upper versus lower extremity. And I'm going to talk a little bit about that and also talk about a little bit about the immediate versus delayed. Immediate meaning at the time of a trauma, typically, or at the time of a cancer diagnosis, which we treat quite often here at the Institute for Limb Preservation. So next slide. I take call for upper extremity trauma. I think I'm actually on call tonight, so hopefully I won't get called away. But so when I see these traumas, the most common immediate amputation are fingers. The more towards the fingertip, the more common it is. And so typically when we're dealing with these injuries, first thing we try to do is save them if we can. If I can replant them, I will, but a lot of times I can. It depends on a lot of factors. And so at that point, generally I'll try to save as much length as possible. And there's one exception to that, maybe the reamputation. There's a picture of the reamputation there. Somebody, who's had, you can see that the ring finger because of the scar there. And so they've had a finger that didn't work well for them and got in their way. And so we actually took that whole finger out and brought the small finger and the long finger together. And that tends to be a very functional amputation. And it's also very cosmetic. And although you look at that and say, okay, that's a 3-fingered hand, when they're around in kind of daily living and people don't count fingers. And so they see that as a hand and think it's a hand. When we're dealing with the forearm and wrist, we want to leave enough length for prosthetic wear. And so you'll hear me talk in the next couple minutes a lot about prosthetic wear. And so when we're thinking about a forearm amputation, we want to leave enough room for a prosthesis that has a reticulating or a rotating wrist, and then a terminal device. And when I talk about terminal device, I'm talking about hands and feet that can have a hand that the fingers move, the thumb moves. And so we really think about prosthetic wear when we get to the forearm. Next slide. And then when we're at the upper arm, this sort of the same thing. We want to leave enough room for a mobile elbow, and then a prosthesis with a reticulating wrist and a terminal device. The one problem we can run into with the upper arm is that those prostheses tend to slip off because there tend to be more heavier prostheses at that level. And so sometimes we'll even think about leaving a little bit of the condyle, which is where that humerus bone comes and kind of flares out to try to catch that prosthesis. Shoulder disarticulations are needed sometimes. They're not a great prosthetic wearing amputation site. And you can see this picture on your right is a patient with a very complex shoulder prosthesis, but they're difficult to wear. They're heavy and they can be burdensome for the patients. And so if we can keep length, we will. Next slide. Lower amputations, toe amputations, certainly we see a lot in orthopedic surgeons and podiatric surgeons treat those. There's a couple different levels of the foot for amputation. Transmetatarsal is where we take all the toes off but leave the rest of the foot. Symes is where we're leaving just really kind of a heel pad. We leave the calcaneus and a heel pad so that the patient can walk on it, but there's no real foot there. It's just it's almost a peg with a heel that they can walk on. Below the knee, it has a big advantage from an above the knee amputation because we keep the patient's knee. We want it to take off enough length to be able to, again, get a nice terminal device on there, but we want to leave enough length so that we can get a good fitting prosthesis. Next slide. Through the knee is a little bit controversial. Some practitioners and prosthetists and physical medicine rehabilitation doctors like that length. Some don't like that length. It can put your knees at different heights. And so a lot of times we won't do that unless somebody's a bilateral. Above the knee, we want to have enough length to drive the socket and enough room for that prosthetic knee. So we have a bending computerized knee and then a terminal device. This is an above the knee picture you're seeing on the right. It's actually an osteointegration I want to talk about in the second part of my slides. And then, hip disarticulation, we try to avoid if we can because it's not favorable for prosthetic length, but sometimes is necessary. Next slide. All right, I will pass it over to Guy.
Thanks, Dr. Schner. And just a quick reminder to our attendees, if you're having any technical issues, please don't hesitate to reach out to Kelvin Tavares in the chat and he can help you out. And also still keep taking notes on some questions you want to ask later on. So often that next step after surgery is rehab. And I'm really pleased to welcome Guy Lev, who's one of just a leading expert in coordinating rehab and amputee care, to share some of the educational side of things and what steps look like in that rehab. So Guy, welcome, and over to you.
Thank you, Jenna, for that really nice introduction and the opportunity to speak, as well as thank you to the Limb Preservation Foundation for all the work that you do. So my name is Guy Lev. I'm a physical therapist over at UC Health. I primarily work with the amputee population, and I direct the rehab component of our Osteointegration program here at CU. And I think being a physical therapist sort of offers a unique perspective and also an opportunity as part of the care team for folks with limb loss and amputations, because we see people over an extended period of time, several weeks, several months, over years. And at the same time, that also instills in us a certain responsibility because of this opportunity to be a guide to people and to be able to be the hub of the wheel, so to say, for all the medical providers, because we see people for long and we're able to connect all the medical providers, as well as be an advocate for the patient. So I know we have both providers in the audience as well as PTs and patients in the audience. So I'll try to sort of speak to everyone. Next slide, please. So do your research. Now, I know not everyone gets the opportunity to do something before it happens, but oftentimes people do. And if you do get that opportunity, this is a great time to build your support network and a great time to build your team. The amputee world has lots of new things to it and lots of support available if you only reach out to look for it, such as the Limb Preservation Foundation. So reach out to support groups, reach out to peer supporters, and really get ideas and advice and the kind of pearls that only someone who has gone through an experience like that can give you. That's really the only place to find that type of information. And I think as providers, it's really our responsibility to know where those resources are and to help our patients connect to those resources. I also think it's really important to, if you can, build your medical team prior to your amputation. I mean, anything to do with limb reconstruction, limb loss, is a very complex process. It's really important to build your team to understand it, interview different people, connect those folks, make sure they're communicating amongst themselves, get second opinions if you want to. And the most important thing is to be comfortable with your providers and know that they're in your corners. And I think for us providers, one of the important things is the most important thing is to make sure that we make people comfortable with us. Even if people need to fire us, we should make them comfortable with firing us. Next slide, please. You don't know what you don't know. This is true because being a member of this new limb loss community, there is a whole new language, a whole new culture, a whole new resource enterprise. And if you know how to navigate it, you're just going to do better. So knowing the language allows you to communicate what's happening, understanding what's going on, and then being able to communicate what's going on, even being able to ask the right questions. Because if you don't know the language, oftentimes it's even hard to ask the right question of the right person. It's also important to know the culture, because there are a whole new set of activities, peers, there's a whole new set of etiquette, the whole new set of possibilities, and it's important to know all those in order to navigate this. Finally, I think there's kind of a whole new set of providers that you may have not even known that existed, such as prosthetists, and you got to say the word right, physical therapists, surgeons, physiatrists, psychiatrists, social workers, peers, supporters, etc. And I think that it's really important to know your team, know what each one does, so that you can ask the right questions, communicate the right things with the right person to get the outcome you want. I think it is up to us as providers to really teach that language, to know it and to teach it, to introduce folks to the culture, and to educate folks on the resources that are available. Because only then are we truly able to empower our patients to be as independent and highest functioning as possible. Next slide, please. Can we do the next slide? Actually, and then there we go. Thank you. So, a little bit about the equipment as well. Prosthetics and orthotics are just high-tech, complicated pieces of equipment. And those pieces of equipment only work really well when they're understood well and when they're used well. It's really important to listen to your body, to take your time with this process, to follow the instructions of how to use, whether it's using your socks and your plies correctly, or adjusting to volume changes, or building up your tolerance by a wear schedule. And I'm getting back to that, the language of this world, of this community. But all those are so important. The other thing I'd say is that the old adage that an ounce of prevention is better than anything else is absolutely true. So prevention is better than any treatment possible, and avoiding skin or pain issues from the beginning by just slowing down and listening to your body makes a whole huge difference in the long run. It's important to know your equipment, to treat it well, to keep it clean, know its features. And I think as providers, and particularly as physical therapists, it's really important to know that while a lot of this information originally comes from the prosthetist, who really is a subject matter expert on a lot of this, our understanding and knowledge of all this is so useful because we are the ones that are seeing the patients through the entire process. And so it's really useful so that we can reinforce it throughout the whole thing. The previous slide, please. Thank you. So the long game. What I mean by that is that it's so important to understand the time frame for recovery. It's really important to understand what is the surgical time frame recovery, how long, and to plan accordingly, and especially to plan your world around you, your home. It's also important to know when in the process you start with prosthetic fitting and how long does that take, what is the process for that, and how long does it take then to learn how to actually use it. I think one of the more meaningful things that I always get out of my patients and those that participate in our support group is that they tell me that while it may take a few weeks, a few months to 4 to 6 months to learn how to use, for example, the prosthesis as an above the knee amputee, it really takes a couple of years to really integrate it. And I always think that, when someone undergoes an amputation, their brain is not amputated. And that's what really needs to change to really fully integrate. And that takes more than a few weeks, a few months. That takes a few years. But to have the patience and the understanding that things will change for the better, and it takes time to do this. I think that setting realistic goals, attainable goals, is really, really important to help patients along that road, along that process. And I think that as providers, our opportunity is that we are the ones that have the experience, since we see this time and time again. And so that way we can guide folks through the process and help people set those attainable and realistic goals. Thank you for your time, and I will pass it back to Jenna. Thanks, Jenna.
Thanks, Guy. I think you put together a lot of practical and thoughtful tips there, because oftentimes there isn't a manual for these sorts of situations. And so what you just shared is very helpful guidance. And I think what you also get at is sometimes it's the things that we see, and sometimes it's the things that we don't see. And I think that's a great segue to welcoming Maggie Savely, who's a trauma nurse specialist and has just a wealth of experience, especially with the Trauma Survivors Network. So Maggie, I'd like to welcome you up and share a little bit of your perspective.
Sorry, I don't know if you guys can hear me, but my video just stopped working. Can you see me?
We can see you and we can hear you.
Perfect. Okay. Thanks, Jenna. Sorry, I'm usually the one who has the technical difficulties, and that is not shocking at all. So thanks, Jenna. Thanks for the great introduction, and I really appreciate the opportunity to speak to you guys. This is a great crowd to talk to, especially about this particular subject. Just to elaborate on my personal background, I'm originally from Mississippi, and I had most of my training as a trauma nurse in Memphis, Tennessee, which was a sink or swim kind of training especially for trauma. I really appreciated everything that I learned there, and then I continued to work mainly at inner city level 1 trauma centers throughout the country, mostly in the Southeast. And then I moved to Colorado in 2016. So I've continued to be a trauma nurse out here. I've got a little bit of medical ICU background, but my career has mostly been focused in trauma. I really enjoy working with trauma patients, and the resilience that they have to offer impresses me every day. So I'm really privileged to work in this particular industry. Next slide. So I want to talk a little bit about my role in the hospitalization period for trauma patients. I have a pretty unique role at Denver Health. I am a trauma nurse specialist, which means I cover all of our trauma patients who walk into the door from start to finish. So which means that I see them as soon as they walk into our emergency department, and then I'm with them and follow them until they get discharged. The really great thing about having that type of occupation is that I build relationships with those patients from the minute they come in, especially them and their families or their support group when they walk into the door. This helps me build a relationship throughout the hospitalization, which is amazing, and I make those connections during the hospital stay, and I help them through explaining what happens during hospitalization. I explain specific injuries, which includes limb injuries and limb loss patients, and then I go through what it might look like after discharge. So from my experience, trauma patients normally can't see past the next day, so it is really difficult for people that are currently in the hospital to know exactly what they're going to need 3 months down the road. So what I do is I kind of show face. I do a lot of support within the hospitalization to make sure that they're at a good period when they leave to know what all has been educated to them while they're in the hospital, especially about injuries after they get discharged, but also how to do their follow-up. So when I started working here, there was a really great opportunity for me to start the Trauma Survivors Network, which is really amazing. It is actually a support group and a support system that's sponsored by the American Trauma Society, and they give hospitalists a really great platform to build off of to create the social support and community support for their trauma patients. So what that looks like is me trying to get them access to all the resources that I possibly can, because there is a huge aftermath of limb injury and loss. So you guys all know, since you work in this field, that there are challenges beyond a physical recovery from trauma and trauma injuries. And so there's an extremely important emphasis on recovering physically, and that's an incredibly important step to go through when you're doing the recovery process. But what we try to offer as a social support and a mental health support is to treat the patient as a whole person and not just a limb. And I think Guy touched on that, which I really appreciated. There are tons of research out there throughout the nursing vascular system and the NIH that talks about rehabilitation psychology. We all know it's not unknown to us in the medical community that when you support people in a social and mental health and community way, that patients recover better and faster. So even if you didn't lose a limb from a gunshot wound or a motor vehicle crash, all limb injury and limb loss is traumatic. And sometimes we don't realize that treating the patient as a holistic system is incredibly important to their recovery. Next slide. So like I said, there's a ton. I just wanted to list a couple of these to give you an idea, and I'm sure that most of you guys already know about this. But it's important to realize that resources are available. I think most patients, specifically the ones that leave the hospital, aren't even aware that these things exist, right? So educating yourself on what is available is incredibly important, but it's also important that you have providers and people in your medical system that know about these and can give you that information. A lot of people aren't aware, and I think that that's the greatest thing about what this has taught me, this experience of building the Trauma Survivors Network, is that there's so many more resources in our community of Denver. We're very lucky to have these resources, and there's so many more than I thought would be available. Sometimes they're very injury specific, like the ones that are listed here, and other ones are quite broad. Next slide, please. And I also wanted to touch base on this, which is something that a lot of people don't feel super comfortable talking about, but I think it's a really important topic to address. Like I said, that there are some resources out there that are super injury specific, like the Limb Preservation Foundation is one of those resources. And there's legal and financial and social support out there that are also very injury specific. But anybody who goes through anything traumatic can also default to have coping mechanisms that aren't healthy. So as providers, we try to recognize those things, right? Anything that a human being goes through that is traumatic for them, they're going to experience things like anxiety and depression. And so addressing the mental health of a patient is just incredibly important in their recovery. So what I would say to that is that if you're a physician or another healthcare provider, the thing that you should be doing is know what to ask. So check on your patients, recognize signs that they need a support group, or they need to be involved in community somehow, or they need to talk to somebody about mental health, and just recognize that that is an entire person that you're treating. And if you don't know the resources, there's plenty of people that you can ask. People like me exist all over our hospital systems everywhere in Denver, and there's great coordination amongst us. And then for patients, I would encourage you to not be afraid to advocate for yourselves. Again, sometimes you don't know what you don't know, but there is a benefit to just having a conversation, recognizing that amongst yourself, and really pursuing that and not being afraid to ask your physician, your surgeon, your physical therapist, because they're going to be the ones that also know how to address that and send you in the right direction. So that would be, my best advice for all parties is that we come at, recovering from huge limb loss injuries as treating the patient as a whole. So with that, I will turn it back over to Jenna. Thank you.
Great, thanks, Maggie. Yeah, another great collection of information and just a great guide there that you've pulled together. I'd like to welcome Dr. Schner back up as we continue the journey here on some follow-up procedures. So Dr. Schner, back to you.
All right, thanks, Jenna, and thanks, Maggie, and thanks, Guy. Those were both very excellent, informative talks with some excellent points. So thank you to both of those, to both of you guys. So next slide. So this is sort of, this is kind of my true love is the secondary procedures and sort of late considerations in amputee surgery. So I'm going to talk to you about some various aspects of secondary procedures, mostly in the lower extremity, but also in the upper extremity as well. And again, this is something that really, that I love very much, and I'll probably go over my time by a couple minutes, so I apologize. But so when we're thinking about or when we're evaluating the patient, an amputee who is having an issue with function with their prosthesis, what we want to do is sort of exhaust all prosthetic options. So, so if they're having pain, we want to be sure that the prosthetists, and they're very good at this, really, adjusting the prosthesis as best as possible to make it so that those areas that are painful are offloaded. And many times the prosthetists can treat these patients who are having pain or problems or functional difficulties. And then, there's sort of two main reasons that I see patients for late revisions or secondary procedures. One is pain, probably the most common, and the second is to improve function. This picture on the right, you can see, is an above the knee amputee who has a large area of skin graft that was put on his stump. Not a great to have skin graft on a stump. A lot of times we'll have to come back and do something creative to try to get rid of that, to give more native tissue. Next slide. So let's talk for a minute about pain. I sort of, in my mind, certainly I break pain down into two different categories. One is mechanical pain, and the other is neurogenic pain. Mechanical pain is pain from some structure, anatomic structure, that is usually causing too much pressure in the prosthesis that's causing pain. A lot of times it doesn't have enough soft tissue coverage over the top of it, especially in the lower extremity, most commonly in the below the knee amputee, who has a very prominent tibia. The front of that, the leg bone, is the most common place to have a lot of pressure there, that it's difficult for the prosthetist to offload that, and we may have to think about ways of getting some soft tissue coverage there. And then I'm going to talk a little bit about neurogenic pain as well. So again, going back to mechanical pain, if we can eliminate the offending structure. So a lot of times we'll see patients with bone spurs. Sometimes, like in the below the knee amputee, the fibula will be a problem. We like to keep the fibula if we can, but for some patients, that fibula is causing too much pain, and we end up taking it out. So if there's a structure that can be removed or flattened or burred down, we'll try to do that to get less of a pressure point for those patients who are experiencing pain from a very specific anatomic structure. And then the other kind of the flip side, which I mentioned again before, was if we can improve the soft tissue envelope. The most common way of improving the soft tissue envelope is to shorten the stump a little bit, and then take the soft tissue that's there and get it, typically over the end. And the most common time I see this is, again, the below the knee amputee. I'll occasionally see it in above the knee or in the upper extremity. And if we can shorten them and still keep them with a decent length, then we can get some better soft tissue coverage over there and give them a better stump that can function better in a prosthesis. Sometimes we'll have to think about taking tissue from another part of the body, or something we call a free flap, where we'll take tissue and we'll transplant it, and we've got to hook it into an artery and a vein under a big microscope. to be able to get more tissue into that area. This picture on the right is a patient who was in a truck accident. He was driving a truck when he got into an accident with another bigger truck. And he did not have enough soft tissue in that area. This is an above the knee amputee. And so we didn't want to really shorten him too much. So we just took some tissue from his abdomen and transplanted it down to his leg and skin grafted it to be able to get enough soft tissue there so that he could keep the length of the long below the knee amputee. Again, skin graft on that area, but it's an area that doesn't bear a lot of weight, and so that's a skin graft that's better tolerated. Next slide. So neurogenic pain. So neurogenic pain comes from, basically the cut nerves when an amputation is done. So whenever we cut a nerve, peripheral nerves, nerves not in the spinal cord, want to regenerate themselves. And so they'll try to regenerate themselves, even if there's not a place for them to regenerate. So if a nerve's cut and we have the other end of the nerve, we'll sew that nerve together so that the nerve can regenerate down the other end of the nerve and get to eventually where it was. Now, in the amputee, that nerve has been cut and there's nowhere for that nerve to go. Doesn't stop the nerve from trying. It will sprout what we call axons, which are the little tubules that carry the signal, and it'll try to find another, axon or another a nerve to grow down, and it won't find that, and so it will kind of form this scar ball of nerve, and those can be sometimes not painful. Again, every amputee has them, but sometimes they're very painful. And so one of the things that's been developed relatively recently that works better than the things we've done in the past is something called targeted muscle reinnervation. And so we've done all kinds of things in the past, like cut these back, we've put them in bone, we've put them in muscle, just dropped them into muscle. And we've wrapped them with all kinds of things, and that works sometimes, but not all the time. With targeted muscle reinnervation, the idea behind targeted muscle reinnervation is we take that nerve, which is typically a sensory nerve, giving sensation to some part of the body that's no longer there, and sewing that into a little nerve that's going into a muscle. So that nerve then coaps to the nerve going into the muscle, and then that sensory nerve giving sensation will actually dock into the muscle. And we found that there is no longer, or at least can decrease the amount of pain that's being generated from that nerve. Additionally, those nerves, and we don't understand this very well, are very important in modulating phantom pain. So pain that an amputee has in the part that's been amputated. And we found with targeted muscle reinnervation that it helps with the phantom pain as well. In fact, and studies show that it helps with phantom pain probably a little more than it even helps with the nerve pain. It was targeted muscle reinnervation. I'm going to come back to it. It was originally developed to improve function, but and I'll explain what that means. But we found when we used it to improve function, we improved pain as well. That's the schematic on your right is the brachial plexus, so that the nerves coming from the neck that typically go down to the arm in someone who's had the whole arm amputated, so a shoulder disarticulation, and the nerves going down to the upper arm to straighten and bend the elbow, but also down to the hand to open the hand and close the hand, have obviously been cut, but they've been rerouted and put into the chest muscle, the pectoralis muscle, both in this case for function, but also for pain. Next slide. So let's shift gears with targeted muscle reinnervation and talk about function. So the idea behind targeted muscle reinnervation and the reason it was developed was to improve function. And so this schematic on the right is the upper arm amputation, or what we call the transhumeral amputation. So there are nerves that go down to the hand that move the hand around in space, namely the median, radial, and ulnar nerves. And in an above elbow amputation and shoulder disarticulation, those nerves have been cut. So when we get a myoelectric prosthesis, and probably most of you are familiar with myoelectric prosthesis, where we can pick up the signal from a certain muscle and transmit that to the prosthesis. We've been very limited in the past on what muscles we can pick up in the upper arm, basically the biceps and the triceps. So, you put an elbow on there, you put a wrist on there, and you put a terminal device hand on there. And a patient thinks about bending their elbow, and the elbow bends, and then straightening the elbow, and the elbow straightens, picking up the signals in the arm. But then they've got a mode switch, so they've got to co-contract those, and then they've got to think elbow up to close the hand, and elbow straight to open the hand, and that's not very intuitive. So what was done is we took the nerves that originally did that, the median, radial, and ulnar nerves that did that, and we've sutured them into muscles in the upper arm that are available. And so now that nerve, which originally, let's say, closed the hand, is going into half of the biceps, that muscle that raises the elbow. So we leave half of the biceps as its native innervation to lift the elbow, bend the elbow. And we take the other half of that muscle and we put the median nerve in there, so that when the patient thinks, close my hand, that other half of the biceps fires. We can pick that up and send that to the prosthesis. And that way the prosthesis can close, and it becomes much more intuitive for the patient. And we can do that with the triceps as well, with hand open, taking the radial nerve that goes down to open the hand and suturing that into half of the tricep. So really pretty fascinating stuff, and pretty remarkable stuff. Next slide. And that's, again, improved function for the upper extremity, above elbow and shoulder disarticulation patients tremendously. The other thing I want to talk about, which is a really exciting recent development, or relatively recently development, for the lower extremity amputee, but also can be used for upper extremity as well, is osteointegration. And what osteointegration is implanting a device. Let's use the above knee amputee as the example, because that's where it's most commonly done. We take a device, a rod, and we implant it into the femur bone. And the current device that we're using, we do in two stages. So we'll implant the device into the femur bone, let everything heal, and let that implant grow into the femur bone. And then about 3 to 6 months later, we'll come back, we'll open that up, and we will put another device that goes through the skin and out the skin and lives outside of the body. And then close everything back up. And you can see the picture on the right. That first picture is a patient who has this, it's called the Oprah system that we're using here, that has that device that comes through the skin. And then we let that heal. And then the prosthesis attaches directly on to that abutment that's coming through the skin, that piece of metal that's coming through the skin. And you can see what that looks like in the schematic next to it. And again, that's the Oprah system that we're using here at the Institute for Limb Preservation. And it does two things. It does actually a number of things. The first is it eliminates the socket. And so a lot of times above knee amputees will have a lot of difficulty with their socket, with poor fit, with sweating, with pain, with breakdown, and it eliminates that. The next is it makes it really easy to put these devices on and off. The patients can get their prosthesis on and off in about 30 seconds or less, when before, to put that socket on and then get it seated and then put the prosthesis, get it all hooked up, a lot of times would take them upwards to 5 to 10 minutes to put on. So it decreases that time tremendously. And then the third thing it does, which is probably the most important thing it does, is it really allows the patient to feel. So they can get some sensory or haptic feedback through the femur bone, and it allows them to feel the ground again, which they couldn't really do in a socket. So if someone's walking on an uneven surface with their prosthesis, they can feel it. If they're walking on a slope, they can feel that slope. And so being able to feel the ground, which is something that people with two sound legs don't think about very much, is very important to an amputee. And being able, for example, to walk into a crowded room and look out into the crowd rather than having to look at your feet, so that you can, because you can't feel the ground, you've got to look at that ground to be able to walk in. It's a big game changer, and it's something that I think is really the future of amputee care. And I think more and more what we're going to do is combine targeted muscle reinnervation and osteointegration to really give a prosthesis that's integrated into the patient. Next slide. Here, this is the first patient that we did the Oprah system on, and we did him about 1.5 years ago. So again, relatively new technology, although it's been used in Europe and around the world for much longer. But there's about 500 plus out there, and doing, many of them doing very well. But this is our first patient, and he had not walked for 9 years. And he had lost his leg. He was a police officer in Florida and lost his leg chasing a bad guy. And so we did, and he had a lot of pain issues, but we put this Osteointegration system in, and this was about 3 weeks ago. He climbed to the top of Mount Elbert with his prosthesis. Again, something that he certainly couldn't have done before Osteointegration. In fact, he couldn't walk before Osteointegration. So this was a proud moment for all of us, and he's a tremendous person and a very resilient man. And it's it almost brings tears to my eyes to see this picture with him at the top of Mount Elbert. So I'm happy to answer any more questions. But again, I want to thank everybody for coming, for joining this Zoom meeting tonight. I want to thank Marcy for all the work that she did putting it together, and Kari at the Limb Preservation Foundation. Thanks, Jenna, for your great work as a moderator, and thanks to Guy and Maggie as well. So thank you all.
Awesome. Thank you, Dr. Schner. What an inspirational note to wrap up on, just after some compelling ways to improve functionality and really quality of life. So with our last 15 minutes, I'd like to welcome all of our panelists to turn their cameras back on and get ready for some questions and answers. So for all participants, please remember to use the chat box to pop in anything that's on your mind, questions, comments. And I see we have a question regarding prosthetics and how successful it might be for someone with AKA who may have dementia, but also a full-time caregiver. So this might be something for each of our panelists to respond to.
This is Guy speaking, and I can take this one at least to start. So that's interesting and not uncommon, as most folks have multiple diagnoses whenever we're dealing with anything. But I think that the answer to that is generally yes, and it really comes down to two things. So how do you define success? So going back to some of the things that I said before of setting attainable, realistic goals. If you define success within that realm, and your team can help you set those goals through their experience, then the answer is yes, you can reach success. If your goal, and of course depending on the level of dementia and the level of the amputation, but if your goal is to generally be able to get around the house and be upright and be with your family, then the answer to that is yes. So that's, I think, is important, the definition of what success is. And then the other one I'd say about that is making sure that you have the right equipment. And that's particularly where prostheticians come in and help with that. And like Dr. Schner was saying, technology is moving at an amazingly quick pace. And on the prosthetic side of things, more and more technology is being built to make prosthetics a safer tool to use. And so these days, even some of the more complicated and expensive microprocessor needs that I primarily use for higher functioning individuals, and maybe at the athletic level or definitely at the community level, are now being built for people that may be just using them inside the home or at a lower level, but yet provide the intuition and the safety that only comes from these microprocessor needs. So hopefully that helps.
Thanks, Guy. We've got another question around preferred surgical techniques for intentionally surgically creating a residual limb that would work well in a prosthesis. So maybe Dr. Schner, do you want to start on that one?
Yeah, no, I'd be happy to. So I think that question came from Jeff. Thank you, Jeff. So, that's it's a broad question, and I think it sort of depends on, what level we're looking at. You had mentioned an ERTL in your question. And so what an ERTL is, and it's named, it sounds sort of like an acronym, but it's actually named after Dr. ERTL, who was the first one to perform these procedures, was to, for a below the knee amputation, is to take the fibula and cut it, leave it a little bit long and cut it, and then swing it over so that it's attached to the tibia. And so that instead of just having two bones that are not attached to each other at the end, you've got those bones, that the larger tibia bone and the smaller fibula bone attached to each other, giving you a stable platform to wear a prosthesis. And that's really a great operation, especially for very high functioning people. Downside is it takes a little bit longer to get to rehab, but that's a great procedure. When we're talking about the above the knee level, osseointegration, I think, is a fantastic tool, and I think it's certainly the tool of the future for an above the knee amputee. I think it'll be for, very possibly for below knees, which is being done primarily in Australia right now, for the upper extremity as well, especially above the elbow. It's right now a secondary procedure, so you've got to have sort of failed traditional socket wear first. And then, and as far as the upper extremity amputations, like we talked about, targeted muscle reinnervation for the above elbow shoulder disarticulation, I think really, gives a huge advantage. We'll use it in the lower level amputations and lower extremity amputations for pain. You had asked, it's kind of a separate question, Jeff, about thoughts on targeted muscle reinnervation as an immediate procedure when the amputation is done. And that's being done more and more. We've done it a number of times here, a lot of times with patients who have cancer diagnoses, who were doing amputations for cancer treatment. We'll do an targeted muscle reinnervation right then and there, either for pain or for improved function. And I think we'll see more and more across the country, as more and more centers are doing targeted muscle reinnervation, that this is done at the time of the original amputation and not as a secondary procedure. So.
Thank you. And, we've got a lot of interest in osseointegration, which, by the way, there were some just compelling news stories of your patient and what he's triumphed with osteo. So, one question around the severity of phantom limb pain, but then also, have you begun doing osseointegration on below the knee amputation?
So Guy's team, and you can weigh in, Guy, I think you've done a few of them. We have not done them. We've stuck to above the knee, which is probably, I'd say, the most reliable level for doing osseointegration. Again, there are some systems that can be used for below the knee. There are some that can be used in the upper extremity. In Australia, there's a physician in Australia who's doing a lot of these. And he's done a number of below the knees. I think the complication rate with the below the knees we're going to find is a little bit higher than the above the knees. But I think that as the technology progresses, we're going to see osseointegration at the level below the knee and above upper extremity amputations as well. I don't know, Guy, did you want to add to that?
Yeah, I mean, the basic answer is yes. We've done about a dozen or so below the knee amputees as osseointegrated amputees, and we have several of them that are bilateral or up, above knee on one side and below knee on the other. And just a couple of months ago, we did, in a sense, our first primary amputee. So this was a gentleman that had an accident. It was a helicopter accident, and he had severe burns over the majority of his body. He went to Australia and had osseointegration done as an above the knee, but had an orthotic supporting his other side, which was not very functional. And he decided to go for osseointegration because it was so successful on the upper extremity side. But so we decided to do him as a primary because he knew what he was doing. It wasn't his first rodeo since he had it on the other side, and so far successful. So we have done it on folks with below the knees. Dr. Schner is correct. I do think that the overall the risk is higher for below the knees rather than above the knees. So that's always something to keep in mind. But so far we've had pretty good success with folks. And the other thing I wanted to say, I think it was a question a little bit about phantom pain. I think it is important to know that the indication for osseointegration is not necessarily to relieve pain, but rather to relieve the discomfort or inability to use a socket. From all those things that Dr. Schner was saying with proprioception, the elimination of the socket, the ease of taking on and off, all those are the main components of why we do osseointegration. Pain is secondary. Pain is never a sure thing. In particular, phantom pain is never a sure thing that it can be eliminated by eliminating the socket. And I think that's important to go into it. Again, setting realistic expectations, knowing what you're getting into it. In my anecdotally, or at least in my experience over the last couple of years working with this population, it does help with phantom limb pain, particularly probably since the osteoproprioception, or that if phantom pain is in some way an indication of the body and the nervous system wanting something, wanting some sort of input, that is the input of the muscles and the nerves and the joints moving and not getting it, and osseointegration being able to help someone normalize sensation and mechanics of movement, then the body, in a sense, gets, and the brain, which is the interpreter of pain, gets some of that feedback it wants, and it does appear to help. But it's pretty much anecdotal on my end.
Yeah, and I tend to agree with that. It's not a treatment. Osseointegration is not a treatment for phantom limb pain, but I do think it helps for the reasons that the guys outlined. And then a lot of times when we're doing osseointegration, we'll treat the nerves as well, either with TMR or something called RPNI, which is regenerative peripheral nerve interface, where we'll wrap the nerve ends in a muscle graft, taking some muscle that doesn't have blood supply to it. And there's some thought that can help the phantom pain as well.
Maggie, anything you want to add on that question or topic?
Oh, no, I think they did a really great job of answering that.
Great. Well, so we've got time for one more question. What type of self-management strategies could be helpful for phantom pain? Throw this out to all of you.
Yeah, you want to talk a little bit about that?
Yeah, I'll take a couple of these points. So from the conservative side of things, that is from rehab and physical therapy, so first of all, what I like to tell people is a little bit of what I said before, is that we think phantom limb pain is when someone undergoes an amputation, the limb, along with all the soft tissues, including the nerves, get cut. However, the part that interprets those signals, that is our brain, is still there, hopefully. And so that the brain is asking for these, what it's used to the entire time. It's not getting the same signal. And for some folks, unfortunately, it interprets it as pain. And that's what we think phantom limb pain is primarily. And so the first thing I tell people is that just creating a certain level, giving the body some of that input, a certain level of normalcy helps. So as people go through an amputation process, at the point they can develop pains, and we try to let people know that oftentimes, as soon as they start the prosthetics process, they will get a respite from that pain, because, for example, just compression from what we call the shrinker that you put on, and then later on the compression from your sleeve and your socket helps give the nerves and the brain some of the input that it's so desperately wants. And then as soon as you also start to walk, that also usually helps people, because again, we think that some sort of normalcy, that is the weight bearing and the continuous motion of walking, is also something, again, the brain is striving for from all those nerves that you go to control the musculature and the joints that are associated with walking and moving. So that helps as well. The other treatment technique that I'll mention is what's called mirror therapy. And the level of evidence is relatively low, but the evidence appears to be good within that level. So mirror therapy is another technique for, in a sense, tricking the brain, whereby we use a mirror and we place the mirror. So visually, what we can see is the sound limb. Let's say if the amputation's on the right, you see your left you can see your left leg. And because of the handedness or the mirrorness of the mirror, the left leg appears as your right leg. And then you do a bunch of movements under that condition where you're looking at that right leg in the mirror. It's really your left leg, but it looks like your right leg, and you're going through movement. And that actually has a really, again, low number of participants, but a high level of what appears to be decrease in pain, especially phantom pain, with kind of practicing that technique. And again, we think that the brain is looking for a certain level of input, and here's a way to give it. So anybody can Google, or I'm happy to talk more about mirror therapy as a treatment technique.
Thanks, Guy. And with that, our hour together is about up. But before we conclude, I do want to just share a few reminders that, again, we will be sharing these slides out via email as well as on our website. And if we can bring the slides back up, we never want to miss an opportunity to just share the opportunities with the Limb Preservation Foundation, whether it's sharing the resources, becoming a volunteer, attending these symposiums, or even if you're able to, becoming a donor. So please do think about ways to continue sharing the message and the resources of the Limb Preservation Foundation, and just really grateful for the participation tonight. Tremendous amount of questions and thoughtful comments in the chat. And if we didn't get to your question, please be sure to reach out. But also to mark on your calendars, in April of next year, 2022, our plans are to host one of these symposiums live. So definitely want to get back in person, have some great exchanges of thoughts, and just know that we'll be following up with you with more information on our live gathering in the spring. So one thing that I talked about earlier was a little bit of an incentive, and that was our $100 gift card drawing, and it's time for that. And so I'm going to ask Maggie to pick a number between 1 and 72, and we'll see who the lucky winner was.
Let's go with 32.
32. All right. So congratulations to Cheryl Gross. You had lucky number 32. We'll be following up with you afterward to make sure that you receive that gift card, and thanks for your interest and attendance. So if we can move on to the next slide here, again, there's great ways to stay connected with the Limb Preservation Foundation, whether it's LinkedIn, Facebook, or Instagram. Visit us on our website again to get the download from tonight. But just want to share a huge thanks to our expert panelists this evening, Dr. Schner, Guy, Maggie. Thank you for bringing all of us along on the journey, and also just sharing that there's real hope, help, and possibilities for limb recovery. And to everybody who gathered tonight, thank you for being here. We look forward to remaining in touch. Marcy, appreciate all the organization tonight as well. So with that, great gathering. Have a wonderful rest of your Thursday night, and we look forward to seeing you again soon. Thank you.